So I did my OB-GYN rotation at Abilene Regional Medical Center, and I saw a 22-year-old white female who was a new patient presenting to the clinic for a well women's exam. And during her exam, she stated that her menses have always been heavy and prolonged since menarche at age 15 and wanted to discuss the possible treatment options. She also said that she was terrible at taking scheduled oral medications and wanted to learn of other alternatives besides oral therapies. Her last menstrual period was on 10/9/15. It was characterized as heavy on most days due to bleeding through clothes, despite use of a tampon and a pad, and her menses are cyclic and typically last 9 days. She denied pelvic pain, abnormal vaginal discharge or odor, and pruritus. She is recently married and sexually active and wanted a form of contraception. She denied any past medical history and has no surgical history. Her family history includes a maternal aunt with breast cancer, diagnosis at age 62, and a father with hypertension, and she denied tobacco, alcohol, and drug abuse. Her only current medication was a one-a-day women's multivitamin. Her pertinent physical exam findings include a BMI of 22.7, blood pressure of 118/76. Her pelvic exam showed external genitalia was appropriate for age with normal hair distribution and no lesions. Urethral meatus was normal and non-enlarged. Vaginal walls were pink, moist, and well rugated with normal tone. Cervix was normal with no lesions or discharge. Uterus was anteverted and normal size with no tenderness or palpable masses. The labs that were ordered and pending include a pap smear with high-risk HPV DNA, gonorrhea, and chlamydia amplified assay. So a pelvic exam with pap smear and a clinical breast exam were performed at her visit, and no significant findings were found. She was given a diagnosis of abnormal uterine bleeding and counseled on the available treatment options for heavy menstrual bleeding, as well as treatments used for contraception. And after considering her age, sexual activity, and her personal preferences for treatment, the Mirena IUD was inserted in office, and the patient was scheduled for a 6-week follow-up. So this patient case reminded me of all the treatment options for abnormal heavy menstrual bleeding and how they all differ in efficacy and acceptability and administration. So it led me to the clinical question, which was, is the levonorgestrel releasing intrauterine device more effective than oral medical therapy alternatives at improving heavy menstrual bleeding in non-pregnant women of reproductive age? And the article that I chose that was the best evidence was a Cochrane systematic review. That was a review of 21 randomized controlled trials comparing intrauterine devices versus other medical therapy alternatives for heavy menstrual bleeding. And this article review involved over 2,082 women. Some of the other medical therapy alternatives that the IUD was compared to was mefenamic acid, tranexamic acid, a variety of combination oral contraceptive pills, a progesterone-only oral contraceptive pill, and even endometrial ablation and hysterectomy. And most of the studies that were included used the IUD Mirena as the device to compare the other therapy alternatives to. And the primary outcomes considered were menstrual bleeding measured by either objectively with the alkaline hematine method, which was just a method to measure the improvement in blood loss, semi-objectively with the pictorial bleeding assessment chart score, or subjectively by patient perception, which was important to measure the quality of life aspect, which better reflects a woman's personal experience with the burden of heavy menstrual bleeding and should be considered during treatment. So the main findings were that the levonorgestrel IUD was associated with a significantly greater percentage reduction of menstrual bleeding from baseline when compared to the oral contraceptive pills and other oral medical therapies, and this was shown by the alkaline hematine method and PVAC scores, and both of those values showed favor for the IUD. Other findings included a consistent lower PVAC score after treatment with the IUD for 6 months compared to placebo, and the IUD appeared to be equally effective as endometrial ablation, but not as effective as hysterectomy. And so, in conclusion, the levonorgestrel releasing IUD or Mirena is a more effective treatment for heavy menstrual bleeding compared to the oral medical therapy alternatives, shown by a greater reduction in heavy menstrual bleeding, improvement in quality of life, and more acceptability long term. The only limitations and weaknesses found in this review were that there was inadequate reporting and inconsistency of study methods between trials, and patients weren't blinded due to the necessity of self-reporting of majority of the primary outcomes. So, what I will take away from this review as a provider would be to consider an IUD such as Mirena when treating a reproductive age female who is having heavy menstrual bleeding because of its overall greater effectiveness, advantage of being a pill-less therapy, and its long-term contraception. But I also take into consideration each patient's case and preference in order to make sure the patient chooses the medical therapy option that's best for them so as to improve their quality of life and decrease the health complications and burdens involved with abnormal uterine bleeding.